Okay, so these are some things I got from psychiatry website. And basically, these are hematological studies. It gives you the basic procedure, what you're testing, what the values are. Typically, these are based on their standards. And then it's what's the indication for doing it, and then what the outcome is, like some comments about what is it going to tell you, okay? So the MDQ. Was what is expected elevation for chronic pain. Okay. Mood disorder questionnaire. Okay. Alrighty. And then over here we're looking at another, this is a continuation of the hematological here. And then we got platelets on down, reticulocyte, white blood cells, so on. And again, here over here on the far right, some comments about it, like you see here, platelets decrease in certain psychotropic medications, carbamazepine, clozapine rather, and phenothiazines. So that sort of summarizes some of those studies that you might be looking at getting. And then these are serum chemistries. Here's your amylase, maybe elevated in bulimia nervosa. Okay. Young Mania Rating Scale. Okay, you like that? It works out real well. I don't have it. I'll have to get it. Yeah, I thought most of them are clinical research tools, right? Yeah. Does anyone use the SADS for bipolar? Not me. Oh, okay. All right. So we go ahead a little further here. Get rid of this. More serum chemistries gives you some implication what it might be doing, like the chloride associated with mild elevation of hyperventilation syndrome, panic disorder, that type of thing. Schedule of affective disorders and schizophrenia. Thanks. More chemistries, vitamin A, B12, partial workup for metablastic anemia and dementias. That's why we're always doing it for the dementias. And then there's some endocrine studies down here, cortisol, etc. You'll see excessive levels in Cushing's disease. So it gives you an idea. These are printable, and that's what you should do, is you should just print them out, and they're a good way to sort of look at labs and say, okay, this is what I'm looking for. And then more endocrine. Here's your prolactin. They will definitely ask you about the prolactin. I'd be real surprised if they didn't. Some of them are, not all of them. But what is evident when you go through the chapter in the update, you're going to find that they say, well, this is a clinical measure versus this is a research measure. So what more likely they'll be testing you on is more clinical. They expect you to remember a few numbers, you know, like basically the total white cell count, what's generally normal, and what might be pathological, like if it drops below 3,000, that's a serious issue. I don't recall that they're going to do that. I don't think there's anything like that. For platelets, they might say that the patient's manifesting some easy bruisability, what might be their cause of this kind of thing. Now, you know, yeah, toxicity of lithium is always asked. It's always asked, you know. They want you to know what's a maintenance dose, what's initial treatment, what your levels are, and what you're going to do for maintenance dose, and then the side effects of lithium. And we're going to get to that in a moment. We'll talk about some other things about assessments. Okay. Yeah, you mean when does Peter, you're putting that as when it starts to be toxic at 1.4. It is toxic at that point, but not as bad as it can get. So they might want you to distinguish mild versus moderate or severe. Okay? Jump the gun. Okay. I think there's CSF, some autoimmune studies you can think about. Let's see, cerebral spinal fluid. They're not. I don't know that they're going to ask anything about that. Here's your urine screen, urinalysis. Let's see. These are just interesting to read through. It gives you some idea of what labs can do for you. That's why I put it out here, actually. I think it's more than you would actually need, far more. Okay, these are routine screenings here. Okay, and then this is sort of based on clinical judgment, a suspicion. So complete blood count with differentials, normal, serum, chemistries, that type of thing. We'll get to those things in a little later today. Routine screenings, considering so on. So this is like for each. If you look at the illness at the top, new onset psychosis. This is what they're suggesting you want to do, and these are other things you might consider. You go to here, in this case, it's depression or manic symptoms. Again, here's your routine screen. These are some of the other things you might want to do. And then same thing here for anxiety. So it's giving you most of them. It's like a little nice tool to have. Put it in your head. Altered mental status. So you see the folate, the B12 here. Okay, and then what you're going to do possibly after, based on the outcome, if you see something that's clinically suspicious. And again, this is for cognitive impairment. And these are the things to consider. This is very similar to what the previous one was. And then these are your substance abuse assessments. This is the toxic levels here. On down the line, urine detection, alcohol, 48 hours amphetamines, 24 hours, 3 weeks, that type of thing. I think there should be some more here. No, they're not. I was looking for marijuana. Oh, there it is, cannabis. Yeah, 4 to 6 weeks. And then these are your levels here. The assessment tools over here. You can see this is considered 1.8 to 1.2 to be normal range. Above 1.5 is beginning to show evidence of toxic response. If somebody's at 1.5, they should be showing you some coarse tremors. Excuse me. These are some levels. They do ask a couple levels, as I recall. It was mostly related to the amitriptyline. And nortriptyline is one of the few drugs that has a therapeutic window. You all know that? It's one of the questions typically. Nobody's saying anything. I think we might be falling into a lull. Break time. Yeah, I guess. Let's see. We started this at 10, 11, 12, 1. We might be coming up on lunch, though, for here real soon. Like, because we've done 1, 2, 3, almost 3 hours. We've seen lithium and valproate levels on practice questions. Yeah, they do ask that. I hadn't gotten to the, I don't think the anticonvulsants are all here yet. Do we see the other ones? I don't know if they put it. Yeah, there it is. Yeah, ED levels here. What they're going to ask you is to distinguish between a toxic and a normal level. Yes, they were there on my version of the PAP. Lunches is in 20 minutes, so the class is 7 hours, not 6. What's that mean? I'm only supposed to teach for 6 more. 6 hours today. We're splitting it, 8 and 8. He's got 8. What's a Northrop-Grumman window? A window is that if it's under 50 or over 50, it won't work. It only works between 50 and 150 nanograms per milliliter. Lunch in 80 minutes? Lunch in 80 minutes. No, we can do that. That's fine if everybody else wants to do that. We'll take a little break and then we'll come back and do some more work. All right? 20 minutes for lunch. What? You see the ECG as necessary with small dosage of TCA for sleep management. Not unless there was some obvious reason that I was concerned about it, like a real advanced age, but I probably wouldn't be. In most cases, I would probably, with that type of person, try trazodone first. It'd probably be as effective at a low dose. Yeah, it's 20 minutes till lunch is what we're supposed to be doing. So if we just sit here for another 20 minutes and gab, we'll be... wait. Anthony. Morning session was supposed to be 8 to 12? 4 hours? Who told you that? So we're not supposed to have a lunch? Yeah, in 16 minutes. That's what we're supposed to be doing, right? 3 hours, and then we take a lunch break, and then 3 more hours. Okay? That gives you my 8. Can you explain coarse tremor again? Most of us, when we stick our hands out, hold our arm out and straight, and we look at our fingertips, spreading our fingers like this. I guess you could see that. Let me get this. I'll go to the window. Okay? So, like this. I got an opposite here. Let me find it. There we go. Okay, so now if I hold my hand out like that, no matter how hard I try to hold it, it's going to shake a little. Okay, it'll just shake a little. That's normal. Okay. Now, a coarse tremor would be like this. It's really easy to see. It's like that. It's real easy to see. And it's usually, a coarse tremor is usually a slow amplitude. Its oscillations are slower than those fast, fine tremors that we all get, okay? Yeah, YouTube probably has some videos on tremors. There are different types of tremors. Okay? But most of the time we talk about tremors of rest, tremors of intention, that type of thing. Christine has an important question. What's Christine's question? Where is it? It's up above. Can you explain course? Oh, yeah, I just did. Okay. Short lunch when that time comes. Okay, whatever we do, it's fine. I don't care. Tony wants an hour. Yeah, I'm going to eat. I know that. YouTube has some videos on tremor. You're answering it. Okay. Does it stop when you intentionally move the affected part? You can try to mask it. Yeah, you can do some things to mask it. But like with patients that have like a Parkinson's tremor, it's it's interesting because their tremor is coarse. It's sitting there typically when it's resting on their lap and it's moving. Their hand is moving. In the beginning, there's usually one part of the body that's moving in an uncontrolled way. And then there are almost like twitches or some movement. I've had a couple patients come back and they say the muscles in my arm are jumping independently in that one area, and it's always that one area. So that was, in his case, that was the early sign of his Parkinson's. But most of the people will show Parkinson's symptoms with their hands, and you'll see one hand sitting on the lap, and it just has this coarse tremor where it's kind of like this, and it's just like it's resting on your lap, and it's doing this sort of circle motion type thing. total course today is supposed to be 8 to 4. That would be 10 to 6. Yeah. Yeah, I know they say that, but what they forgot about was you're supposed to have 16 hours, right? That's the total course, correct? 8 and 8, correct? Right. So if you add up 8 and 8, 2 yesterday, 6 today is 8 for me, and the other 8 is Taggart's. Unless he wants to give me more money. I don't think he'll want to do that. 7 on Saturday, yeah. I don't know. You see, it's crazy because there was no, when you think about that, we're splitting it. We do 8 and 8. How are you going to do that? We're not one hour with me on Friday and 1 hour with Taggart on Friday, and then 7 and 7. I mean, they didn't think about that. And we never got to a point where we could do anything about it because once we discovered that his wife was ill, there was little else that we could do. And so I said, well, okay, I'll just cover Saturday. I'll do Friday evening, and I'll do the rest on Sunday. Anyway, I'm not really so worried about time. I want to give everything I want to give to you before I quit today. That's really my goal, okay? I'm not going to argue about time. Okay, whatever. All right, thanks. We'll work it out. I just want to make sure you get it, okay? So anyway, I think we're not going to break for another 10, 15 minutes, so let's finish up this, okay? Let me get this out of my way. So pay attention to the nortriptyline level. You might want to look at this. Because amitriptyline has an active metabolite, you have to think about the actual total amount in the serum as a combination of the two, the active metabolite, which is nortriptyline. So amitriptyline is broken down into nortriptyline. Okay. And then doxepine also has one. It has a metabolite that you have to consider. Here's imipramine. Imipramine is broken down into dizipramine. And those are things you probably need to know about, especially if you're looking at blood levels. Okay, so I would pay a little attention to that stuff. You notice that the antipsychotics that were listed in this, you don't see anything about levels, right? So that tells you a whole lot. They don't mean anything. Could you go talk about the window? Okay. So the window we were talking about, I thought I answered that, but I'll do it again. Let me go back. So I missed the answer. Okay. Well, see, if you're looking here, you see it says 50 to 150 on nortriptyline. That means if you're under that dose, you're not going to get a therapeutic effect. And if you're over that dose, you're not going to get a therapeutic effect. It's only within this window that it works. That's what they mean by therapeutic window. Certainly it would be toxic if you're above 150, but not necessarily severely toxic. You've got to go a little further than that. But the point is, you want the dose to be in that range. And I think there's one other one, and I have to go try to remember which one that is. Off the top of my head, I just can't think of it. I'll have to find out about that window for you, the other window. That's what I'm wondering. But where are you seeing that? The toxic level is within the therapeutic window. No, not on nortriptyline. No, it's outside when it's too high. So it won't work unless it's within that window. Should be greater than. Is that a typo with toxic level? What are you reading? Oh, here. I wasn't even paying attention to that. I think that's a typo. Because the level, the window is 50 to 150. So I think that's what they mean. That should be greater than 150. Okay, so that's got to be a typo. Thank you for catching that. Yeah. Okay, there is a typo. Should be 500, not 50. Where are we looking at? No, it should be 150, above 150. Maybe 500. You're right. It could be 500, Jessica. I don't know where they're not going to ask you that toxic level. That's why I'm not too concerned about it. If they're going to ask you anything, it's this therapeutic window. So I don't know if that is 500. It stands to reason it probably is 500 when you're looking at these others that are talking about 150. So it probably is 500, not 150, as you correctly pointed. So let's say it should be 500 because following suit, looking up at these 1, 2, 3, right? Above, the imipramine, desipramine, the doxepin, desmethodoxepin, and then the amitriptyline, nortriptyline. Okay, they all seem to be saying 500, so I suspect this should be 500 as well, now that I look at it. That's my confusion. Doesn't make sense. What doesn't make? Okay, that makes more sense. Right. Okay, got it. All right, good catch. All right, factor 2. No, the Mayo Clinic's, their clinic says it's 300. Whatever. I wouldn't worry about that. Question is, how many of you are going to get normotriptyline or triptyline? It's going to be pretty thin. You have so many other options nowadays. Why would you do that? Unless you're giving a small dose for some other purpose, like maybe resting a little bit better or dealing with some headaches. But then you're going to be probably subtherapeutic, or you would be in the window, but you're not doing it for a window for depression. In this case, you're doing it for migraine headaches. Yeah, so it's completely different. All right, so we're done with this one. These are the CYP enzymes. They're substrates. Okay, here we have these various substrates metabolized by specific enzymes. So we have the CD26, the CD19. These are inhibitors down here for these two particular enzymes. You've seen all that stuff before, I'm sure. There's too many medicines for you to memorize all those, right? It's not going to happen. So you have to try to narrow down where you think it's important. Try going over that again. 3, about what? Going over what again? Oh, okay, you got it. Okay. So you have these poor metabolizers, intermediate metabolizers, extensive metabolizers, and ultra-rapid. This is sort of an idea of what it's going to be like, okay? This is the expected response over here. This is the number of active enzyme or gene alleles. None for the poor metabolizers. Okay, intermediate metabolizers, 1 active and 1 inactive allele, are 2 gene alleles with reduced activities. So here you have 2 alleles here, the extensive metabolizers, and then greater than 3. So they just kind of give you an idea how this might show up. So poor metabolizer has no alleles to metabolize the drug. So the reduced metabolism of the drug may result in increased concentrations and more adverse effects. Do metabolizers change rate over time? You mean for the individual? No, it's a genetic. It should be genetically predetermined. And if the person cannot metabolize a drug, it's not going to change. They still can't metabolize the drug. Okay. And then if you have an intermediate metabolizer, less extent of adverse effects. So when you can't metabolize a drug, that's when you have the risk of toxicity, right? Okay, everybody. Are these familiar? Yes. They're genetically determined. Extensive metabolizers, expected to respond to a standard medication, and then the ultra would be they would chew the medicine up. So in the old days, if somebody came in and you gave them a 10 milligram of Prozac, and they said, oh, it was making me feel strange, I felt lightheaded, in those days we would have said, oh, this person's just a little wacko, we'll just go ahead and tell them to stay on it, and try to force them to stay on it. And it could be very well have been that this person actually was just a poor metabolizer and was having major side effects because of it. Because the way we treat medicines is like a shoe size. We pick out the number and we say this is the one that should work for this person, and it doesn't always because we didn't really consider any of that stuff up until really the 90s when it started to become more evident. And you guys, I know that they didn't talk a lot about the problems with genetic issues for glucuronidation. That's another area that we're not even really dealing with yet. That clearly is different and affects metabolism. These are some genetic markers for illnesses. Uh-oh, what happened? Sorry. I lost you. Somehow I jumped out. Oh, it's because it's time to break.
You're still there, Doctor. What's going on?
My screen went funny, so I'm just having to open it up again. It just kind of blanked out. Maybe there it is. I got it. All right. Okay, so we're almost done for this. Okay, and biomarkers. So you can look through these. These are helpful to look at. I don't know how many you're going to want to memorize. I would sort of look at them as more in terms of just giving me some basic information. And if you're unlucky enough to have to answer one of these obscure questions, you just have to do the best you can do. Okay? I think that's too much to memorize. Uh-oh, I lost you. Where am I? I'm getting an echo too. Yeah. Did I jump out?
You fast forward first to the end of the presentation and then to the beginning.
Oh, okay.
You're back in it right now.
I'm going through it right now. Get back to where we dropped off. This is just information about how things appear on various radiological entities like CT. Okay, and then this is a compare. I have a echo.